we see the side effect profile or adverse event of sacubitril valsartan versus enalapril in paradigm trial, the commonest is being hypotension, which was more pronounced with the ARNI as compared to the enalapril, and second was hyperkalemia, where it was again around 12%, followed by cough 9%, and then impaired renal functions and angioedema. Though they were lesser, but they were comparable, or in fact to an extent better than the enalapril. If we see numerically, hypotensions were more common in ARNI as compared to the ACE group, while hyperkalemia and cough were more common in enalapril arm as compared to the ARNI arm. And that's why the risk of hyperkalemia associated with the use of concomitant mineralocorticoid receptor antagonist was lower if the patient is treated with ARNI as compared to the enalapril. So implication will be, if patient is on ARNI, more safely we can add spironolactone or eplerenone. If he would have been enalapril, we can expect in fact more issues of severe hyperkalemia or a rise in the potassium. So ARNI is safer for rise of potassium or cough, while angioedema and hypotensions were more common, and we should be cautious about it. There are no strict contraindication except use of ACE inhibitor. You are switching from ACE to ARNI, you will have to stop for 36 hours minimum. Optimal is 48 hours. If there is a history of angioedema with or without exposure of ACE or ARB, still it's an absolute contraindication. History of angioedema, no ARNIs. Then others being routine, like a lactating mother or a pregnancy or a severe hepatic impairment, then these patients are relatively contraindicated for ARNI. Maybe more important is where we should exercise caution. See, if there is mild to moderate renal failure, like 30 to 60 GFR, generally there is no dose adjustment requires, but we should be more careful about worsening of renal failure or aggravation of hyperkalemia. If it's a severe low GFR, that is less than 30, we can start with much reduced dose. Increment can be more slower, but with better monitoring. In case of hepatic impairment, unless it's a moderate to severe hepatic impairment, we need not worry about the dose. Maybe we can start slow and then go. Yeah. If child poop class 3, maybe we can, better not prescribed ARNI. Then renal artery stenosis, a relative contraindication. Volume depleted patient or hypovolemic patient, relative contraindication, where we should correct the cause of that hypovolemia and then start with the ARNI. If the blood pressure is less than 100, we should be more cautious, start with a very low dose, monitor them carefully, and then up titrate every 2 weeks or 4 weeks.